My dear students, in this video, I'm going to discuss on some of the very important aspects of how to practice end-of-life care in terminally ill patients in Indian ICUs. How to practice, I mean by obeying the laws that exists in India in pertaining to end-of-life care. Let us start with this case vignette. A 75-year-old male with diabetes, hypertension, and ischemic cardiomyopathy with an EF of 30% is admitted with septic shock due to community-acquired pneumonia. Despite being on 14 days with maximal ICU support on ventilation, vasopressors, renal replacement therapy, culture-directed antibiotics, he goes into refractory shock, multi-organ dysfunction, persistently high lactate. MRI brain shows hypoxic ischemic injury with no meaningful chance of neurological recovery. Prognosis is considered extremely poor by the treating intensivists, and there is also no documented advance directive or leaving will. Now, can we let go this patient peacefully, legally in India by legally remaining safe within the ambit of the rules of 2026? If we look into the evolution of jurisprudence in end of life care practice in India, we have to see that the past decade has seen a paradigm shift beginning from Aruna Shanbhag case into 2011, where it was recognized that withholding or withdrawing life support may be permissible in rare cases with high court oversight. Now, this did not go pretty well with the end of life care practice, and a case was filed by Common Cause. Common Cause is the name of an NGO who filed the case against Union of India. And in that case, in the judgment in 2018, there was recognition of advance medical directives or leaving will and the process for withdrawal of futile treatment. Now, that process was also a little bit better than what it was before, but still there were hurdles. So the Common Cause guidelines in 2023 underwent procedural simplification. Withdrawal of life-sustaining treatment could be decided at the hospital level within the purview of the medical boards that was created as per the Common Cause 2018, and with preventing that every time the patient did not have to go to the High Court, which again was a big problem. And finally, when we look into the Harish Rana versus Union of India case, that which came on the judgment which came on 11th March this year, it was the first real life implementation of passive euthanasia under the Common Cause framework, where the Supreme Court expressly directs withdrawal of life sustaining treatment for this man Harish Rana, who was in permanent vegetative state for more than 12 years with a mandated palliative and end of life care plan within the hospital setting. Now, what are the key principles that Supreme Court reiterates in 2026, which can directly be used in our case? If we look into the judgment specifically spoke about that decision is not about choosing death, but is rather one of not artificially prolonging life. It is the decision to withdraw life-sustaining treatment when that treatment no longer heals, restores, or meaningfully improves life. It is allowing nature to take its course when medicine can only delay the inevitable because survival is not always the same as living. Now, this judgment repeated certain basic principles that the specifics of the case are crucial in arriving at the decision. The focus should remain on the best interest of the patient, protecting patient dignity and autonomy. The patient should never be abandoned after withdrawal of treatment. Palliative care is mandatory. And emphasize that euthanasia, that is the actions directed at ending life, continues to be illegal in our country. So, what stems from Common Cause versus Union of India in 2018 was reinforced that the right to live with dignity includes dignity at the end of life, and this is under Article 21 of the Fundamental Right. And what is added subsequently is that passive euthanasia, which the court regards that withholding or withdrawing treatment as a passive euthanasia, and this is permissible. It is different from active euthanasia, and active euthanasia and physician-assisted suicide remain illegal. So in that case, what is the duty of the treating team for assessment of a patient for end-of-life care? Now, this treating team, led by the primary physician, must first recognize and confirm futility, identifying when further disease treatment is only will prolong suffering and unlikely to cause any benefit. They should build internal consensus among all caregivers that goals of care are shifting from cure to comfort, and those should include the nurses and the paramedical personnel, apart from the doctors or the treating team and the intensivists who are engaged in treating that patient. And this team must initiate a clear, honest, and repeated conversations with the patient or family about prognosis, options, respecting their values and preferences. That is, in case the patient's families hold different views, then respecting those views and following as per their wishes. All assessments and meetings should be carefully documented, and any required legal or institutional end-of-life care process, if there is any, requires to be activated. And throughout, the team must ensure high quality of palliative care and holistic support until death, whether or not the patient accepts end of life, but high quality palliative care has to continue. So the next question comes then, what is the role of the medical boards which were created in 2018, and subsequently in the 23 guidelines, there are also clarifications and things became easier. Now, hospital medical boards which were modified in 2023, they provide independent multi-expert scrutiny of proposed limitation or withdrawal of life-sustaining treatment. There are two boards. One is the primary medical board, which consists of the treating physician plus at least two subject experts, each with more than 5 years of experience, examine the patient's, reviews the records, and gives a preliminary opinion, preferably within 48 hours, on whether the withdrawal of the patients is in the best interest of the patient. If it certifies a withdrawal, a second biomedical board of different clinicians reevaluates the case, and this secondary medical board must include an external expert also, who should either concur or disagrees, again within 48 hours of examination. And this certified opinion, along with the consent of the next of the kin, is communicated to the first-class judicial magistrate, creating a document to safeguard the pathway for the end-of-life decisions. Now, this step has been made easier in 2023, that it is not required a formal approval. It is only an intimation to the first-class judicial magistrate is required after obtaining the agreement or the certification of the primary and the secondary medical board. So if you look into this frame, we will make it easier that applicable for patients who have lost decision-making capacity and who are terminally ill. The treatment team is satisfied with these two conditions, and that further life-sustaining treatment could not be beneficial to the patient. So the primary board, consisting primarily of treating physician and two subject experts of more than 5 years of experience, to provide opinion on whether life-sustaining treatment should be withheld or withdrawn. Then the treating team to inform the patient's next kin or next friend or guardian, or those mentioned in the advanced medical directive, if there is any, and through discussion to ensure that they understand the information provided and concur with the decision of the treating team. Next, within 48 hours, we give a secondary medical board with one registered medical practitioner from a permanent panel of such practitioners, which is impaneled by the district CMO, the chief medical officer, and two subject experts with more than 5 years of experience who are not part of the primary medical board. Now, this board will also provide opinion whether this life-sustaining treatment should be withheld or withdrawn. And within 48 hours, if the secondary medical board concurs with the primary medical board, the hospital shall record and intimate the judicial magistrate, and the treating team shall implement the decision to withdraw or withhold the life-sustaining treatment. If the secondary medical board does not concur with the primary board, in this case, if aggrieved, the family or the treating team may approach the High Court. So this is in a nutshell the entire process which needs to be followed. So then what are the obligatory steps which during the doctors have to follow during family engagement and consent? During family engagement, the primary clinician must hold a structured family meeting and should discuss with the relatives the diagnosis, prognosis, the futility of care of further disease-directed treatment in very clear language. The team should actively elicit the patient's values, family's concern, encourage questions, and work towards a shared decision-making about limiting life-sustaining treatment. Once consensus is reached, a written informed consent or acknowledgement of futility and the agreed end-of-life care plan must be obtained from the patient if capacitated for all the key surrogates. And every meeting, decision, and consent form must be carefully documented in the medical record as part of the legal end-of-life care pathway. And there should be signatures of not only the doctors, but also the patient's relatives. So what steps should be followed for documentation and communication? Now, these decisions from recognition of futility to the agreed plan of end-of-life care, this should be recorded contemporaneously in the case sheet with date, time, and name of the participants. Each formal meeting should have a brief summary as to what was explained, the questions raised, and the family's responses with checklists wherever available. The written consent or patient wishes for withholding or withdrawing life support must be taken on designated forms and filled in the medical record. And the team should also document the communication of goals, that is, shift from cure to comfort and ongoing palliative measures in the daily progress note. Now, what is actually meant by the best interest and mandatory palliative care as per the code? Now, best interest means choosing the course of action that most rightly respects the patient's dignity, where his wishes, the relief of suffering rather than the convenience or distress of relatives or the clinicians. In Harish Rana case, the court applied this test by weighing irreversible medical futility against the patient's devastated quality of life and his earlier expressed preferences. Now, this is decided on the basis of the high quality palliative care becomes mandatory. And it should be remembered that it is mandatory, so it is not optional. This includes robust symptom control, psychological support, spiritual support, a humane environment so that withdrawal of life support never amounts to abandonment. The court has become very clear on the term that the patients should not experience abandonment in the virtue of consenting or practicing end-of-life care. So in our case, Vignan, that we discussed, what are the important key steps to accomplish successfully end-of-life care? One, that on the ICU floor, before withdrawal, we will have to initiate pain and symptom control, that is palliative care, with opioids, sedatives, whatever may be appropriate. We have to address the dyspnea, secretions, agitation, etc., and prepare the environment so that end-of-life care can be implemented. And during and after withdrawal of life-sustaining treatment, you monitor and treat the distress, provide psychosocial and spiritual support to the family, ensure that the staff understands that this is a goal concordant care and not a neglect. So they should not ignore the basic needs of the patients and the relatives just because they have accepted end-of-life care. So the Supreme Court in 2026 verdict explicitly linked withdrawal to a structured end-of-life or palliative care and warned that directly jumping to euthanasia without any such plan may be an abdication of medical responsibility. So all intensivists, we need to be careful about it. So my final take-home message would be that in order to practice end-of-life care in the ICU, one has to recognize and diagnose futility, build internal consensus first within the team, then initiate end-of-life care discussions with the patient's family members or the surrogates, and document and trigger the formal end-of-life care process with consent from the patient's relatives, including signed documentation, and always ensure ongoing palliative care and holistic support. Thank you very much.